This is Going Under, Anesthesia Answered, brought to you by the Butterfly Network. I'm Vahid Sadurzadeh.
And I'm Dr. Brian Schmutzler. When it comes to successful ultrasound-guided procedures, precision is everything. That's why IQ3, Butterfly's handheld POCUS device, contains advanced features to support procedural success. With Butterfly's needle out of plane preset, you can visualize the needle tip within 1 millimeter after insertion. Butterfly's biplane imaging, the only multiplane imaging in a handheld ultrasound, lets you see both short and long axis views simultaneously in real time. And Needle Viz enhances your ability to track the needle in plane from entry point to region of interest. Butterfly IQ3 also delivers image quality similar to a cart-based POCUS system at 1/10 the price. And unlike a cart, you can carry it in your pocket to conveniently use where you want, when you want. So whether you're inserting IVs, performing regional anesthesia, conducting cardiac assessments, gastric evaluations, lung ultrasounds, or anything in between, the Butterfly IQ3 is the perfect probe for your practice. Visit store.butterflynetwork.com to claim a soft case with the purchase of an IQ3. Use code BRIAN25 at checkout. Terms apply.
Ah, you had one of those.
I do.
Yeah, it's going to be a fun one, too, because we're going to be talking all about the Butterfly Network and the Butterfly IQ3 and POCUS handheld devices.
Yep.
Because we are both like fresh off of the plane from Boca Raton, Florida.
That's correct.
It's like we were just there.
It is.
We were
much warmer there.
80 degrees in Boca Raton, Florida.
It was beautiful.
And it is 15 degrees here with
snow.
Lots of snow.
But we made it. We made it. We sat in the airport for a while, but we made it. So we got to attend the Butterfly Network inaugural POCUS Innovators Forum. Really, really cool. Really good time. Met a ton of people. Not a lot of anesthesiologists. Met a lot of people in other specialties. Some anesthesiologists there, but in other specialties as well. And hoping that I can collaborate with them both clinically and on social media going forward. So.
What is, for those of us who are kind of new to this technology, or not technology, but the glossary of terms here, what does POCUS mean?
Point of care ultrasound. And I think you and I talked a little bit about this because you asked me that question as we were
I did.
down.
Well, got to ask it for the folks that are not physicians.
Exactly. So basically what that means is we can take an ultrasound, we can get an image, we can use it to diagnose and treat right on the spot. I'm not sending it to a radiologist, waiting 4 days to get a result and then deciding what to do. So point of care, the point of care is the patient, so we're using that point of care ultrasound. There's other point of care systems as well, meaning point of care labs. We talked to Dr. Lasserson about that. So you can take blood and get a lab right away and that sort of stuff. So that's what point of care means, and then point of care US ultrasound.
After you do the interviews and we play the interviews, I'll tell you what I really loved about this conference, because it was one of the first of its kind that I've attended. More of an innovators conference too. So investors and sales and physicians who are using this not only all over the country but all over the world and trying to adopt this kind of technology. So I'll explain what I really, really like. Just intro the people that you spoke to really briefly.
Sure, yeah. So as I said, I did speak to one anesthesiologist. You guys may know him. Is Jerome Adams. This is a former Surgeon General of the United States. Actually, and I may have told this story before, he was an attending when I was a resident. So he taught me how to do blocks and all kinds of stuff. So actually, even when I was a medical student. So I've known him for a long, long time. It's kind of funny because we've got some things in the works with him as well. And we just so happen to be in the same place at the same time. So I got a chance to chat with him. Dr. Lasserson, who is, I think, the equivalent of internal medicine in England. And he'll talk a little bit about something which to me was completely foreign, but an amazing, amazing idea, which is hospital at home. And then I spoke with Dr. Risa Lewis. She is an ER physician in Philadelphia. Had a really cool perspective about how they're using POCUS and how they kind of changed the way they did triage, which is a big part of emergency medicine. Again, way outside of my expertise. And then also spoke to Russ Horowitz, who's a pediatric emergency medicine physician in Chicago. And he talked a lot about how and you'll hear it on here, but basically, and again, something I don't really think of, a stethoscope on a kid is about impossible to do, but putting an ultrasound on there is much, much easier. So we'll go ahead and get to the interviews and let you guys enjoy them. This is Dr. Brian Schmutzler at the Butterfly Network POCUS Innovators Conference, here with actually someone I've known for quite some time, probably 15 years at least. Dr. Jerome Adams, former Surgeon General of the United States, also does a lot of cool things around the country and in Indiana. Jerome was actually one of my attendings when I was a resident at Wishart Hospital, which then became Eskenazi Hospital in Indianapolis. So, Jerome, will just tell us a little bit about kind of your journey and how you ended up here at the conference, and then we'll talk a little bit about the conference itself.
Well, I do a lot of different speaking engagements now, mostly related to health and health equity. I'm the Director of Health Equity at Purdue University right now, and this is a great example, Butterfly in this conference, of using innovation to achieve health equity, really taking something that has been inaccessible to the majority of the population and making it accessible. So, when you talk about the meeting today, we heard about work being done in Africa, work being done in Ukraine, work being done all over the world, but also in austere locations in the United States that are really improving health for people.
So in terms of global health, do you feel like that the Butterfly IQ3 would be like a game changer, obviously, something that could really improve, the lives of millions of people remotely and kind of all over the world. In terms of, and I'll ask you just because I'm an anesthesiologist and so are you, what do you think the role of POCUS and the Butterfly would be internationally in terms of anesthesia? Do you think there are ways we can use it internationally for global health?
Well, it's fascinating because one of the things I always talk about is how care costs so much in the United States.
It's true.
And so I think there are two main pathways we can go with this. Number one, we can make care faster, cheaper, higher quality right here in the United States. We can do everything from fast exams to making ultrasound-guided nerve blocks more available, to vascular access, to lung exams, and these are going to improve quality of care. We heard from several speakers today about how they're improving quality of care right here in the United States with point-of-care ultrasound. But beyond that, we heard examples of use in obstetrics in Africa to actually improve outcomes for people who don't have access to an OBGYN. Just amazing, amazing story. So I think there's one pathway in terms of global health and another pathway in terms of improving care right here in the United States.
Yeah, no, I mean, totally agree with that. It's been really cool. And I don't know, we also heard from a fellow in England who hopefully we'll talk to later, who does home hospital, which I thought was really cool as well. So hopefully we'll talk to him a little later. So tonight, you're giving a presentation. What are you going to talk about tonight?
Well, tonight I'm just going to talk about the state of affairs here in the United States. Like I said, high cost, limited access, and not the best quality, at least from an equitability standpoint. I do believe we have the greatest care available here in the United States, but only few can access it and afford it. And to me, that's really the key here. It's democratization of a technology that previously only a select group of people had access to, ultrasound. So we're going to be talking about that broader picture. We're going to be talking about the climate we're in the United States, a lot of frustration on the part of the public about lack of access to high quality, affordable care. And we're going to talk about some lessons learned from COVID. And COVID is another great example of how a lack of diagnostics actually really hurt the entire planet. And so I hope that we can, after this meeting, leave people invigorated to take up and to share the message about point-of-care ultrasound and really save some lives.
Yeah, I'm definitely excited to hear that. So we've asked everyone, this is going out not just to the POCUS community, but to the medical community, and then through social media to the community as a whole. So if there's one thing you'd want to tell all the followers out there, everybody who follows me, who follows Butterfly, who follows the community as a whole, what would that be?
Well, the one thing I would say is that everyone deserves access to the best quality care. And if you are a provider, then you should really learn about point-of-care ultrasound. Butterfly is one example, but really there's so many different opportunities out there for you to provide better care and more affordable care to more people. If you're a policymaker, then I hope that you at least explore point-of-care ultrasound and how its expansion can actually lower healthcare costs. We heard about how we're avoiding unnecessary x-rays and CAT scans and improving throughput through emergency rooms by making point-of-care ultrasound more available. We learned about AI and use of point-of-care ultrasound. And so why do I bring that up? Because we need the reimbursement, we need the regulatory framework, we need the engagement of providers in order to actually bring this great innovation to more people.
Awesome. Well, thanks, Jerome. I really appreciate it.
Thank you.
Good to see you, too.
Yeah, great
it's been
to
a
see
while,
you.
yeah. Here with Dr. Risa Lewis. Go ahead and tell us a little bit about yourself.
Thanks for having me. My name's Dr. Risa Lewis. I sometimes throw in the E, Dr. Risa E. Lewis. I'm an emergency medicine physician, a point-of-care ultrasound specialist. I'm an author, I'm a podcaster, and I'm delighted to be in conversation with you.
Oh, great. So listening to your talk today, a couple things struck me. One is the way that you're essentially using POCUS in the triage in the ER to, improve patient care, to make sure that patients are getting where they need to be faster. It almost makes me think about how, in cardiology they did that, time to the door, time to balloon in the cath lab. And so can you tell us a little bit about how POCUS has sort of changed the way and improved the way that patients flow through and get treated in the ER?
Yeah, I think people probably have had an experience with the emergency department. It is literally the portal of entry. We see everything. When people can't get into their doctor's offices or their doctor's offices close, go to the ER. Nights, weekends, holidays, where do I go? Go to the ER. Now, obviously, there are urgent cares, there's telehealth. I believe in those deeply, but a lot of times the end place, portal of entry, is the emergency department. And so people probably also have the experience of ED crowding, long wait times, nothing that's pleasant for anybody. Certainly, it's not designed as patient-centered. Point-of-care ultrasound inherently is patient-centered. It really helps give us answers and makes us feel that we can provide safer, better patient care. The design of many emergency departments has moved to this triage concept where you get your vital signs and you get, quote, triaged. Sometimes that triage person is a nurse, sometimes a nurse practitioner, a physician assistant. Often in the scope, increasingly for emergency medicine physicians, is doing a triage shift. And you get a bit of a history, a bit of a physical. And what I spoke about in the talk is, and it should be the time for point-of-care ultrasound. These are data points so that together you have more data to make quicker, better, more focused diagnoses and management. And essentially, you don't want to miss the emergent patient. You don't want to get someone going down a pathway that you could have gotten them going 1, 2, 7, 12, 24 hours sooner. Ultrasound allows us to make better, quicker decisions.
Yeah, that's great. And obviously ER wait times, to the public in general, because we're gonna put this out to the public in general. Hearing reduced ER wait times is going to be huge to the public in general. I did want to ask about. So you talked about FAST 1.0, 2.0, 3.0, 4.0. Not rehashing the whole talk, but tell us a little bit about what FAST 4.0 is now.
Yeah. So I really appreciate this question. Thank you. And, it's always interesting to see where we came from and where we are today. So in the talk, I walked the audience through FAST 1.0. The early 90s, trauma surgeons were using the FAST exam for blunt trauma patients. FAST 2.0, emergency medicine physicians grabbed the baton and started extending where we were using the ultrasound to evaluate patients, blunt trauma, but even then non-trauma. 3.0, medical applications like HIV-associated tuberculosis or the FASH exam. So what I talked about today, FAST 4.0, is the focused assessment of sonography and triage. In other words, I believe that whoever is evaluating that patient in emergency department triage, and it doesn't just have to be emergency department, but that's my context, there should be a POCUS unit available to put it over the area that is affected, the abdominal pain, the leg swelling, the shortness of breath, to help answer yes/no questions, add that as a data point to the decision making, and thereby decrease the time to definitive diagnosis and management.
And I like that. Maybe we'll try to get that as a trending, hashtag Fast 4.0. I would say the other thing that I wanted to ask about, just because every administrator I ever talk to, especially in the Catholic health systems where I do some work, is no money, no mission, right? And so every administrator wants to know where's the money coming from. And you made a couple of points of like, oh, that's cute, you're helping patients. But tell us a little bit about how you are able to show administrators the monetary value in POCUS.
What I think is particularly funny about what you just shared is Catholic hospitals, no money, no mission, because I'm not sure sort of all that sort of like aligns, but it's funny.
Yeah.
Okay. So, I have said, and this did not come from me, but that the state of the U.S. healthcare system, it is a sick care system, not a healthcare system. What I mean by that is we are motivated to take care of patients once they're already sick. Now, I don't loud this, I don't think this is great, but the way our system was built in terms of monetary reimbursement is people come to get care after they're sick. And consequently, people in the U.S. are struggling with chronic diseases like diabetes, obesity, cardiovascular disease, and cancer. And unlike other countries, we don't put money, emphasis, and value in prevention. So where we are today is this sick care system. So we are actually often taking care of patients once they're quite sick. And this goes back to the emergency department being this portal of entry. We're seeing all the downstream effects of these chronic illnesses and these sicknesses, and often in extreme situations. So hospitals aren't working alone with physicians and other healthcare workers. There is the hospital healthcare team, there's the patient, and there's this third person sitting at the table, and this third person party is insurance companies. And the way our system is built historically is reimbursement, and insurance companies sort of have a bit of a hold on how hospitals, physicians, other healthcare workers get reimbursed. So we are very motivated to demonstrate that POCUS provides a means of diagnosis, and it's not just making a diagnosis, we actually capture images. We store and archive those images. We make an interpretation of those images, and then we integrate our interpretation into the patient care. That's a service that is billable. And it's very important to demonstrate that billability, so to speak, because of the way the U.S. healthcare system is. So POCUS examinations aren't just cute, they're not just for fun. They truly are patient-centered. They save time, they save morbidity and mortality, and it's certainly part of what we train for and what we should get reimbursed for in this healthcare market.
Yeah, and I would agree. We personally on my own platforms and podcasts are not particularly kind to the insurance companies, which I think is well deserved. But you make a good point about trying to work through the system and getting paid for the services that we provide. I guess what I've been asking everybody, one last thing, we have a kind of a broad audience, not just physicians, not just medical community, but broad audience in general. What's one thing you'd want to share with a broad audience around the country about POCUS and what we're doing here?
Yeah. So it is true, emergency medicine and POCUS are central to my being. And also, I think it's important for everybody to consider health broadly. Health is a large umbrella. It is our physical health, it is our emotional health, it is our mental health, it is our community health, and it is our financial health. So actually, that's exactly what we're doing here at this conference with POCUS. It is physical, it is emotional, it is financial, and it is community. And I think the more we work together as a community of medicine, the better we will be able to solve this puzzle that is POCUS, reimbursement, and patient-centered care.
Awesome. Well, thanks, Dr. Lewis, and have a great conference.
Thanks for this.
Here with Dr. Lasserson. He's from England, as you can hear, right? So we heard Dr. Lasserson's talk yesterday about his hospital at home and taking care of patients, keeping them out of the hospital, but still treating them for their ailments. So go ahead and introduce yourself and tell us a little bit about what you do.
So I'm Dan Lasserson, and I'm a professor of acute ambulatory medical care at the University of Warwick, in the medical school there, and I spend half my time doing research and teaching. The other half of my time I spend as the clinical lead of an acute hospital home service, and that's based actually in Oxford. So I'm across two big sort of old British cities really, and I head up a team of doctors, nurses, therapists, clinical pharmacists, and our mission is to treat everyone at home with an acute medical illness that wants to be there, no matter what's wrong with them. And we have to just bring our A game in terms of our point of care diagnostics, our clinical assessments, our ability to give almost all the drugs you could find on the acute medical unit, but doing that in the home and care home, which is where our patients prefer to be.
Yeah, and I think that's really cool. Obviously, in the United States, we don't do that well at all. Everybody gets sent to the hospital, basically for every reason. And so you had some perspective on that too. But I thought what was really cool is the POCUS side of things. So you showed a video. I think it was on BBC that did a documentary on you guys. You showed a video of using, the butterfly IQ to examine a patient, figure out that he was in heart failure, treat him at home. So you want to talk a little bit about that?
Yeah. So what I think is the cornerstone of my acute medical practice in the home is the ability to do point of care imaging. It's often the key diagnostic that confirms, rules in, rules out stuff when I'm on the acute medical unit or on the wards. And without that, I don't think I would be able to run an acute hospital service at home. And that's because we are aiming to completely replace the need to come to hospital. So in the States, there are home hospital services, but very often, and I'm told this by colleagues and friends who work over here, that the patients go to the emergency room first. Yeah. They get their workup, and then those that say they want to come home, go home, but those that get admitted. And I think once you're already in the emergency room, the patients often will be disorientated. They might have taken quite a while to get in to be seen. They're fatigued, and you just kind of want to go to a bed at that point. So the ability to do this in the home, I think, for me is a big game changer, because I find that, firstly, I think we're quicker to get to the diagnosis and start treatment. Our door to needle time is the patient's front door and our needle, often in the sitting room or the bedroom or the kitchen, wherever the patient is. And patients will, I think, give us an honest view of what they want. They're really candid with us. In their own home, they are king and queen. Yeah. They're sitting in their own chair, in their own clothes, they're not lying down in a gown in a strange place with everyone bearing over them. Yeah. And so the power dynamics are different. And I feel I can really lock into what patients want. And many would prefer home as long as we can demonstrate and give them confidence that we can diagnose, we can rule things in, we can rule things out, the key things that would help us determine treatment, and we're packing all the kit that we need. So we rock them in their house, point of care ultrasound in one hand, point of care blood test in the other, and the nurses have this huge range of intravenous treatments that they can do. And that for us is key, really, because what makes this system work is the ability to diagnose rapidly, respond rapidly. And that often means that within the time frame of the hospital home visit, we can see the patients getting better, we can see that they are responding to treatment, and they and the family have a lot of confidence that this is a system that will look after them. And as such, they kind of think, well, why do I need to go? Often I get the response from patients, they go, well, why would I need to go to hospital, doc, if you can do this here? And where were you last year? And what about my aunt who lives, So often we get a lot of that. A
lot of referrals.
Yeah. Well, and what have I called repeat business? Yeah. Because patients that we know, particularly patients with heart failure, they'll exacerbate, we'll do burst diuretics, they'll get better, and then there'll be another exacerbation or decompensation, and they come back. And we just started working with a hepatologist for end-stage liver care at home. So doing large volume paracentesis at home, again, ultrasound.
Yeah, are you doing procedures?
Yeah,
nice.
So knee effusion's quite common in the older adults, pseudo-gout, affection mobility, nip in, ultrasound, check that there's effusion, drain. Diagnostic taps. We've got a lot of patients with ascites. What's it due to? Is it neoplasm? Is it liver disease? Is this a bacterial ascites or spontaneous bacterial peritonitis? Key difference. Again, ultrasound proves that it's fluid, safe tap. And similarly, for paracentesis now, where we're working hand in hand with hepatologists. I don't think the hepatologists would have done it on their own, because they're hospitalists, and we go, look, we are acute generalists. We're comfortable with the home as an acute healthcare space, as the acute medical unit for the 21st century. But I don't know nearly as much about liver disease as a hematologist, right? But so us hand in hand, their expertise, our kind of know-how in the home, our POCUS, often we'll just, and with the cloud it's perfect, you share images straight away. And I think this is a great model of generalist, specialist, positive interaction, because often it can be quite adversarial in hospital, where they go, oh no, it's your patient, Actually, I want them to be my patients, but can you throw me a bone when I'm stuck? And they're really keen to engage because they see their patients getting the right care they would give. They see someone else doing the hard yards.
Take some of the work.
Take some of the work, so it's work sharing, and they see their expertise positively. It improves my care as well. I learn loads by working with specialists.
So we've talked about this in the United States. How do we improve adoption, not only of POCUS, but adoption of this home hospital idea? Because for us, I'm a hospital-based anesthesiologist, but I'm thinking of some of the people that come in to get some of the procedures done that easily could have been done at home.
So I think it's about, what's it about? Okay, there's several things. I think the leadership is key. I think people need confidence in what's going on. Sometimes just having an honest conversation with themselves, going, actually, we can do this. It's okay. Give the team the confidence. Evidence what you're doing. Being as skilled as you can be with point of care ultrasound. And I think this is a challenge all of us do POCUS wonder every day, how can I get better? How can I learn more skills? I'm not a diagnostic radiologist. I'm not trying to take over their work. I'm saying, how does this help me in my workflow?
Just the niche when you're there.
Exactly. And I have these conversations a lot of time I've got a lot of friends and colleagues in the US who run home hospital programs. All the patients come from the emergency room, and they just don't want to get involved in that diagnostic space. I'm going, but this is perfect. Well, you could do so much more. And I don't know, because us Brits often get really confused by the American healthcare system.
So do we Americans.
Yeah, we just rock up to work. There's loads to do. Whatever happens, we get the same amount of money.
Yeah.
And so in that space, sometimes innovation's harder because you can't find other money supply. But sometimes it can be easy because you can say, well, we can just do it. Yeah. We're not waiting for someone to pick up a check to say, let's do it. We just see if we can squeeze it in and find out. So we can, at the edges and margins of our work, we can often, let's do other stuff. And that's how we got POCUS in. And it's been a real ride for me, I've got to say.
So you mentioned that there's a large, famous institution that's scared of doing this. We won't name the name. How do we get all the big institutions, the big drivers in America, in American healthcare, to at least attempt to do this?
So I think it's several things. Firstly, it's up to us that do it to kind of disseminate, to give confidence. Because I know nothing annoys Americans more than feeling that the British have got one over on them. So there's a sense of which, look, come and join us up here, and you guys, we'll take it and go further. That's typically what happens as well. You tell what we do and do it better. And once you get
Revolutionary War.
Yeah. So there's something about that. There's a World Hospital Home Congress in Vienna in March. I've got a whole session in that Congress on ultrasound. We're going to be showing some cases. We're going to be talking about having a curriculum for hospital at home POCUS. And then I'm going to be doing a live on-stage demo, hints and tips, have like a mock-up of a hospital at home. Nice. We'll have someone in a high-back chair. How do you scan a kidney when the patient doesn't want to move? It's a day-to-day challenge for me. So to give people that kind of, actually you can just pick it up and do it. Go on a course, get a mentor. With cloud solutions, the support is massive. And I think what's turned this into action for us has been, the price of being able to purchase handhelds, but the cloud function. And then anyone, it's in my team, anyone anywhere, and the nurses can be doing an ultrasound. I get a call, look at it and go, yeah, it's this. They can get a lot of support remotely, so they feel much more confident just to keep going, because they know someone's got their back.
And the quality of the images too. I think, the step up from the initial handhelds, like the original IQ, now to the IQ3 is the quality of the images.
The quality's improved. The quality's hugely improved. To be honest, with the IQ, you can get it. But actually, what helps the specialist get on board, certainly with cardiology, is me showing, here's the echo, I think it's this, what do you think? Yeah. And then they're really happy to engage with complex heart failure patients at home, particularly the ones with venous congestion, acute kidney injury, the really complex wet and poor renal function patients. Who may not have had an echo for a couple of years, and they go, we really want an update. And I go, well, here's this one. Do you want a departmental? Oh no, that one's fine. Yeah. So having quality images so the specialist will recognise, yeah, that's the kind of stuff I would see in our meetings. Yeah, let's engage, and here's what we do. And typically they give way bigger doses than I'd even think of. That tends to be how the cardiologists help you rescue situations. So those things have all helped us. And I think what opportunities like this, meeting to talk, opportunities like the congresses, we've got a new journal for hospital home medicine, which a famous East Coast-based institution is hosting for us for the World Community Hospital Home, and we've got to start putting papers out in there, saying actually, here's what we're doing, here's what's going on, here's the process of care, here's the outcomes, here's how we do it. Come and join us.
Well, so, I could talk to you probably for an hour on this, but we obviously don't have time for that. So what we've asked everybody we've been talking to is, what is one thing, we've got a broad audience, not just POCUS providers, but providers in general, the healthcare community, and the broader community. What's one thing that you would tell the broader community about what you do, POCUS, and anything that you want to say to them?
I think I would say that the POCUS-enabled hospital at home is, I think, the most challenging, fun, patient-centered work I've ever done in medicine, and I would encourage everyone in every specialty to find the work that they currently do in hospital that could be done outside, engage with a generalist hospital home team, support them to deliver more and more, push the boundaries, find out more and more care that we can deliver safely at home, which is what patients want. And then I think that just completely changes how we think about what's the role of the hospital in the 21st, 22nd centuries. I think the hospital should be the kind of place where all that has, the intellectual capital for this stuff, but the delivery is distributed where patients want, and we use all of our intel and point of care testing to say, well, actually, which patient needs to be where at what time, and that will deliver us a much leaner, smoother, patient-centered healthcare that I think will reduce costs.
Well, Dr. Laston, thank you very much.
Thanks
Appreciate
for talking to me. Thank you.
Really happy to talk to Dr. Horowitz, correct? Yeah, you go Russ. Great. Okay. And so Russ is in Chicago, which is close to my home in South Bend. Russ is a pediatric ER doc, correct?
Yep.
And so I'll let you just introduce yourself real quickly before we get into it.
Got it. Thanks very much. I am a pediatric emergency medicine provider at Lurie Children's Hospital, which is affiliated with Northwestern University. I have a couple of jobs there. In addition to being an emergency doc, I am the director of emergency and critical care ultrasound, run the hospital system, and I'm also in charge of teaching our medical students at the Feinberg School of Medicine ultrasound.
So we just heard a great talk that you gave as part of a panel, and I think probably the first thing I'd like to talk about is adoption, right? You have some issues with your partners adopting, the hospital adopting POCUS as the main way to diagnose and then push towards treatment of kids. Again, like I said, we talked a little bit from my perspective. I had a hard time getting adoption with certain regional anesthetic techniques as an anesthesiologist. So why don't you kind of share your observations with the problems with adoption of POCUS versus some of the other things, particularly chest X-ray, and how you're dealing with it and moving POCUS forward.
So I think I've sort of evolved my sort of thought process on this. When I first started, I was super gung-ho and I thought everybody should use it. This is the tool for the future, and if you're not using it, you're going to be left behind. And then I sort of realized that as a provider, I practice a little bit differently than my friend Susie or Susan or Sally, because we each have our own different approaches. And I can sort of make up a name like Ann orders a lot of labs, but Brian doesn't order a lot of labs. It doesn't mean that they're better or worse, it's just they practice a little bit differently. So as I've evolved, I've sort of thought about it in the way that I use point of care ultrasound because that's how I can streamline my care and make decisions faster and come to sort of better decisions. But does everybody have to do that same pattern? I don't think so. I think the more that you can use tools that you find helpful, the better that you can practice and the faster that you can come to a decision. And in my setting, in the emergency department, fast and accuracy is really what's important. So adoption, what I've started to see, and I've been surprised, is I call them the gray hairs in my division, who admittedly are like, I'm not gonna pick up the probe. But what they've realized now is that there's worth. So they will often come to me or other point of care providers and say, can you look at this person's heart? Or can you look at their lungs? I'm kind of worried, I'm not quite sure, so they can see the value. And I can see that as somewhat incremental change. If the gray hairs are starting to see its worth and we're teaching medical students and residents that it's part of what they do, then we're influencing from both above and below to change how things happen.
Yeah, so demonstration and just being, showing that what you're doing is perhaps easier and better, I think, that makes a lot of sense. So then the other thing, and we just had a lively discussion about how a lot of us think that chest x-rays maybe don't give much value in general. As an anesthesiologist, when the surgeons ask me, do you want a chest x-ray, I almost always, with maybe 2 exceptions in my entire career, say no, because it doesn't add any value to anything else that I know about the patient. PFTs maybe, but an x-ray not really. So can you kind of share with me your thoughts on chest x-ray, and then how, and it sounds like from your talk, you've moved away from chest x-ray to primarily POCUS-based lung evaluation?
I think the settings are what's useful. Now, it can make a really dramatic example by saying never get a chest x-ray. That's going to get a good headline, but we don't do everything all the time or never, some things in medicine. So the settings are really useful to describe. Yeah. So what I've sort of broken it down is if I'm the only person who's responsible for what I'm doing, then I can do whatever I want. Right. As I start to involve other people in the hospital, then we have a shared sort of decision-making strategy. Right. Now, will infectious disease ask for more labs than I would do? Sure, but they think about the world in a very different way. Will anesthesia think about or get a bigger view when you're going to intubate? Yeah, in my mind, it's in the hole or in the wrong hole. So, but you have different sort of questions. If I have somebody who has cough and fever, is not hypoxic, and is going to get discharged, then I don't need the x-ray, because I'm going to make the decision on my own. If this is somebody who's incredibly complicated, has a trach, and is ventilator dependent, and has a slight change in what the secretions are like, then that's a bigger decision, and I think the x-ray in comparison to what they've had before can be really useful. And that's how we sort of involve our partners and the other people. Yeah. But what we've started to see, and I'm the first to sort of say I didn't think that this was going to work, was somebody who's an otherwise healthy person who has cough and fever and is a little hypoxic and needs to stay and has pneumonia. The story says pneumonia. Right. He's 5. And I talk to the hospitalist and I say, this is the story. You can see it in the chart. Whether they understand what that looks like or not, I don't know, but they can see my report. Yeah. And they say, you know what, I don't think we're going to need an x-ray today. If he doesn't get better in 48 hours on antibiotics, then we might talk about it. And I'm like, what a logical plan. Yeah. And now we're starting to engage our discussion with the people who are working together, and that's an inherent trust. I believe that if you say to me, this is a difficult airway, I don't need to try it. Right. I trust that you're leading me in the right way. And if I say to you, this otherwise healthy person has pneumonia, and the clinical story fits, and you trust me to work together, then we can say, yeah, let's do it, unless the circumstances are different.
Are you doing POCUS on a patient like that where you suspect pneumonia? Okay, so you're doing POCUS in lieu of a chest x-ray or even like we talked about, maybe better than a chest x-ray. Yeah. And then particularly with kids, this is something we talked about, you want to expose them to as little radiation as possible. And so if the option is, even if they were equivalent, which I don't know, maybe they are, maybe they aren't, even if they were equivalent, you're probably going to lean towards POCUS because there's much less risk long-term to a kiddo.
And the real sort of thing is that obviously x-rays, CT scans involve radiation. We sort of do stuff in medicine, we accept some risk. Yeah, there's pain when we use needles, but we need to get blood. Right. There's radiation, but we need this good test. And often in adults, we sort of say either suck it up, or like the benefits outweigh the risk. Right. The difference in littles is that the radiation exposure gets summed over their entire lifespan. So kids get about 7 to 10 colds in the course of the year, often associated with fever, particularly when they're younger and in the winter. So let's imagine that if the practice paradigm is that we investigate with x-ray. Yeah. They're going to get 5+ x-rays, let's imagine a year for X number of years. And then by the time they get to be 20, how much radiation exposure have they gotten?
A lot.
Yeah. A lot. And that's not the kind of thing that goes away. The more x-rays, the greater chance we know for malignancy. Yeah. And the kids are going to absorb more just by their body surface area. So if we're thinking about what's the best bang for the buck, the thing that's really easy and really accurate that's going to have long life impact seems like what we can use to really make a big change.
Yeah. Well, hey, thanks for chatting with us. And what I've been asking everybody that we've been talking to kind of in this post-game interview is, so again, we have a broad audience. If there's something you would want to tell a broad audience about point-of-care ultrasound, what would that be?
Wow, that's a great question. I think that we're all in this stage now where we understand that technology is powerful, and perhaps our perceptions of what we can do in our life, like multitasking, isn't really true. And so as we've gotten new technology, we realize that our perceptions might not be true. And that's okay. We can adopt new ways of doing things because we can see that they're better. And using point-of-care ultrasound has been proven to be, in some cases, at least as good, and in many other circumstances, better. So we might as well be doing the better test so we can get real good, accurate information. And when you see people who are doing things that are a little different, that's an opportunity for us to say, is this really going to be better? If it is, then maybe I should be using that.
Yeah. That's great. Great advice. Hey, appreciate it.
My pleasure. Thanks very much.
Really awesome interviews that we had that you guys just got a chance to see and listen to. So what really struck me, so I'll give you kind of my take of each of the individual ones. Dr. Jerome Adams and his public health push, and he really, the POCUS idea and butterfly IQ fits into this, in that his big focus was public health. And we talk a little bit about other things, and but public health wise, he says, yeah, this is great to take into the middle of nowhere Africa, but we can use this in underserved areas in the United States. So I mean, that was a cool point that he made. And then his ideas about health equity and disparities and all that sort of stuff. And I'll shamelessly plug his book because I just started that as well. So and then Dr. Lasserson, maybe the most fascinating discussion I've had, mostly because it's so outside of anything I have ever thought of.
Most people have thought of in the industry, I'm guessing, right?
Yeah, I mean, and apparently, and he mentions it in the interview, that actually Medicare does authorize hospital at home. It's just that we just don't do it as a community. But yeah, his whole idea of taking POCUS and basically doing hospital at home, and that the patients in England want to stay at home. They want to be able to have their diagnosis and treatment at home. And we're probably going to do some more stuff with Dr. Lasserson as well. But really cool. Maybe there's some ways that we can integrate some stuff that I do with POCUS and some stuff that he does with POCUS. But again, to me, super fascinating because it's way outside of my area of expertise. And so, as I mentioned, Dr. Lewis was the next one. Now, she gave a really, really nice talk, and then we got to interview her afterwards, about how triage in emergency medicine, adult emergency medicine is what she primarily does, is a tough one because you're overcrowded. You can walk out, you see a patient, you say, yeah, this patient maybe needs a chest x-ray, or maybe needs this, maybe needs that. But then you've got a bottleneck to be able to actually get them in to get these tests done. And she can walk around with her Butterfly IQ3 and just walk up and scan whatever she wants to scan. So it's really fundamentally changed the way that she does triage emergency medicine. And then finally, Dr. Horowitz, and again, this is fascinating to me because it's so far outside of my area of expertise, pediatric emergency medicine. How can I use something that's not cold and scary and associated with doctors on kids, get as much information from that as I could get from doing a physical exam with a stethoscope and all that sort of stuff. And I did like what he said about, he's not forcing the adoption. It's for him, if it's just his patient, he's just going to use the Butterfly IQ3, he's just going to do the POCUS, and he's not going to worry about doing a chest x-ray or all this sort of other stuff. If there's somebody else taking care of the patient, he's going to call that consultant and say, hey, this is what I think's going on because I did the POCUS. Are there other tests that you want? Which I think is a smart way to do things, as much as we want to push towards, what we think in the POCUS community is the way to go. You still got to work within the system. So, my hope is that someday we're able to get all those other consultants to understand that POCUS is powerful enough that they don't need other tests.
I think it was just such a fascinating conference. It was jam-packed
It
with
was.
information.
It was.
Morning until night, and the keynote speaker was obviously Dr. Jerome Adams and his deputy.
Deputy Surgeon General.
Yes. First name was Erica, and I
Yes.
apologize. I can't remember her last name at this moment.
Schwartz, I
Schwartz,
believe.
yes.
Yeah,
we'll
Dr.
we'll link
Schwartz,
it
yep.
below, too. Their bios below. But, man, I just thought it was, why was it a conference like I've never experienced before? Because of the fact that, you usually when you're talking to physicians and doctors, they're so stuck in their ways, right? I'm not saying that as a
No, of course not.
I'm not saying that as a put down or anything like that. I'm just saying it as you go to a doctor, you rely on their expertise, and they've been doing it for so long that it becomes old hat. And I think this was different as to, wow, the future of medicine looks really different than I had imagined.
Right.
The future of medicine is, if it's in this room, it's young and old. It's very much forward thinking. It's very much sharing of thoughts. It's very much technology driven.
Yes. Yeah.
And the biggest question I came with out of this whole meeting is, why aren't health systems adopting more of this kind of technology?
Yep.
What is the holdup? I almost feel bad. Like, if you're a technology sales, like in medical sales, like, man, you have a hard job.
Yeah.
Because it's hard convincing these doctors to adopt, or these hospital systems to adopt things like this. And there's only a couple of people that control it, right? I mean, like, if you look across the world, there's only a handful of companies that control it.
Yeah, GPOs, group purchasing organizations.
So it's tough to break into, but I have to say, kudos to the medical industry if this is the future, because that was exciting to see and witness.
Yeah. I think two things really stood out to me. The first thing is, I have never been to a conference where there are so many different specialties and we're all talking about doing the same thing, right? I go to the ASA meeting, I go to the Indiana State Medical Association meeting, right? It's just not the same. It's not people in a whole bunch of different specialties talking about doing the same thing in different settings.
Yeah.
Which was cool for me, and it got me thinking, how can we as anesthesia, and me personally, use what I know to help these people who are doing really, amazing work, public health work, and triage work and stuff that I don't necessarily fit into in anesthesia, but we talked to Dr. Lasterson about some of that stuff. So I think there's some cool things we can get out of this. The second thing was, a lot of times when I go to a meeting, I'm, on the higher end of the expert level.
Yeah, sure.
And here I was not the expert. I was listening to everybody else talk. They were the experts.
Kind of exciting.
And I was sort of the social media guy, the interviewee, right? Not to say I don't have an expertise in POCUS, but not to the degree of what that meeting was meant for.
Yeah.
So for me, it was kind of cool to be in the audience and just absorbing a lot of it, and then using it to create, in my mind, questions, and then getting to talk to these experts one-on-one. It was a pretty cool experience.
I will say one other thing, and we can start wrapping it up, but I think a lot of us sit back, and those of us who are not in the medical community and those of us who are in the medical community, and we've talked about it at length, I think we sit back and we're like, man, people are using AI for negative things. I came out of this meeting thinking, man, that's pretty darn cool that they're going to use AI for this.
Yeah.
Or they're going to partner with AI companies to use it for this.
Yeah.
And so it's exciting to see AI used in a space where it's going to help people.
Yep.
It's going to help technologies. It's going to help, physicians, no matter where you are in the world. That AI technology is going to help you.
That was probably the most technical panel that they had.
Sure.
And a lot of that stuff goes over my head because I do not have an engineering mind. But it was also probably the most contentious panel. There were a lot of questions. What's AI going to do? How's it going to work? I think there's a lot of fear around AI. I think the panel, though, did a really nice job talking about, this is how we plan to use AI. And the radiologists are already using AI. And you and I talked about this. There's studies that it's, AI is a complement to radiologists in making diagnoses and that sort of stuff. And I think using the AI, especially the AI in the Butterfly iQ3, as well as all the scans that they've uploaded. I can't remember whether millions and millions of scans that are uploaded to then use the AI to then go back and aid physicians in making diagnoses. I mean, it's just kind of a cool idea. We're
going to do a little mini reel on kind of our time down there, just fun.
Yeah.
But if you go to Brian's social media pages, you can see sort of shortened interviews with the physicians as well. Obviously, this podcast has the entire at-length interviews, and then you're doing some collaborative stuff with a lot of different people out there that we're excited about too. So, thanks for a great couple days.
Absolutely,
it was really fun.
And check out, Butterfly Network is going to post a lot of this stuff as well. There's a couple interviews that I did specifically on their platform that we didn't cross over to our platform too. So check those out as well. Got to talk to maybe 3 or 4 other really interesting people as well. So very cool. Just want to thank them for inviting us. That was an awesome conference, and it's a good time.
One thing that did come up: insurance companies.
Yes, it did.
And we're going to talk about that next week.
Next time, we will talk about that.
The ultimate teaser.
Yes, it is.
Stay with us here as we continue our third season of Going Under, Anesthesia Answered with Dr. Brian Schmutzler. I'm Vahid Sadrzadeh. We'll catch you in the next episode.